safe and productive event.
Good evening. My name is Federico Parietti, and on behalf of the SERVIER team, we would like to welcome all of you, the present here in the room, and all the colleagues that they are connected online, through along the West Indies countries. As you know, the SERVIER Academy is an annual scientific meeting focused on the management of type 2 diabetes. The SERVIER Academy contributes to the continuous medical education in the region. In this opportunity, the activity was carried out in the 6 countries in Central America and also in the West Indies. This year, what we want also is to have an exchange opportunities and share opportunities and experiences with other colleagues from the region. So we have here the visit of Professor Rosemary Wright Pascoe from Jamaica. Also, it was a pleasure for me to introduce Dr. Tariq Duki, who is going to give us an overview of the type 2 diabetes in our region. As you know, Dr. Duki is his specialization in internal medicine, and also he's a cardiologist. He's a currently consultant of the Physician of Cardiology and Internal Medicine at West Shore Medical Center, and he's the Vice President of the Caribbean Cardiac Society. So, Dr. Duki, the stage is yours.
Right, thank you. Good night to everyone, both online and on-site. First slide. So thanks again for the cordial invitation of SERVIER. It's always a pleasure to be part of these workshops. As I was telling Professor, there's a lot of cardiometabolic interaction between cardiologists and endocrinologists, and of course a lot of these specialties now. Recognizing, of course, that one disease unfortunately translates into another. So the morbidity of one is very dependent on the presence of another. So we basically just wanted to discuss the sort of diabetic scenario, if you wish, in the Caribbean, and we'll focus a little bit more on English-speaking Caribbean. So this is from the IDF 2021 Atlas, which is really what they publish every couple of years, and it tries to give as best as possible the global representation of diabetes. And it does also give regional information. So Caribbean in itself is categorized as part of North and as part of the Americas, rather. So the data that one reads is not necessarily unique to the Caribbean, but there are some slides that will focus on Caribbean territories. The first concern, I guess, and this is not unexpected, is the actual worldwide prevalence of diabetes is extremely high. And quite worryingly, we see here that is expected to increase by 24% within the next 15 to 20 years. In North America and Caribbean, which is really the upper part of the Americas, we have this quite scary number of 1 in 7 adults being diabetic, and 1 in 4 are potentially undiagnosed. The global prevalence of diabetes hovers about 9.8 or 10%, and of course there are regional variations. With the Caribbean as a whole, this is again referring to the English-speaking Caribbean, is again quite surprisingly higher than the worldwide prevalence, which is at 12%. If you look at within the different territories, these are high numbers if you think about it. We have, if you wish, lowers in the Dutch Caribbean of 4%. We have relatively high numbers in Trinidad, Guyana, Jamaica, Curacao, Barbados, and Bahamas. So generally speaking, we have high numbers. And again, this is for a relatively small population. So percentage-wise, that translates to a number of persons in the Caribbean who are affected by diabetes. And this would not include metabolic syndrome or prediabetes. This is over diabetes. So if you add that broader number, it's actually going to be quite significant. Just to put some scary numbers in context, so if you look at the age-adjusted prevalence, this is again for the Caribbean area of diabetes, Barbados is ranked as number 4 in the Americas, which is again not a good thing to be on that list of statistics. In terms of the actual number of persons affected by diabetes, and of course this depends on the size of the population. Jamaica here is quoted as being at number 5 because their population, of course, is bigger than some of the other territories. And Trinidad boasts, if you wish, on the upper part of the list, the prevalence of younger diabetics compared to the other territories in the Caribbean. So that's, again, bad things. Younger diabetics, a lot of diabetics, and of course a high prevalence rate as well. So we obviously not to undermine diet, but a lot of factors that are happening in parallel. The Caribbean has seen a significant rise in obesity, even in adolescents and young adults. Genetics is much more appreciated than it probably would have been 20 or 30 years ago. And of course, the obesity is quite linked to the type of lifestyle or chronic disease type of pattern that we see now. This was a statement released by the WHO just recently. And this comment really struck out in terms of a worrying saying, where the Caribbean represented the largest increase in childhood and adolescent obesity, which again translates to a lot of early disease in a relatively young population. And of course, the worldwide prevalence of diabetes was 1 in 8. So obesity in itself should not be underplayed as a risk factor, but also as a potentially modifiable disease. If you look at the actual obese and overweight population, this is now again zooming in on the Caribbean, we have numbers exceeding about 60 to 70%, and nearly all the countries are over 50%. Bahamas, Barbados, Antigua, Trinidad and Tobago, Costa Rica, Jamaica, Dominica, Grenada, St. Lucia, Domrep, and St. Vincent and the Grenadines. So again, if we monitor these patients over a period of time, they will have metabolic syndrome and they will evolve into diabetes, and of course all the parallel things that then will follow. So we're going to be seeing a lot of morbidity in relatively younger patients. Functional status, quality of work, ability to work, ability to be functional in society. So it's not just the morbidity, it's all the things that go with that when patients and persons get unwell. The cost, of course, varies from territory to territory, and part of this affects the access to care as well. So if you have a population that has a high prevalence of diabetes in the context of other health economics, then of course you have to have healthcare that's accessible. And we'll discuss that as the talk goes through what will be considered accessible therapies. So although we know about diabetes therapies being more broad now compared to many years ago, the reality is that if you look at the IDF data and the IDF recommendations, the bulk of patients are still using similar types of medications we've been using for the last 30 years approximately. So although we're talking about costs, that's still bearing that in mind. Now, if we compare ourselves, of course, to North America proper, where they have a wider spectrum of some of the other drugs, that's not a comparable thing. But if we compare ourselves within Latin America and the Caribbean, again, these newer drugs, not that we shouldn't use them or there's a place for them, but the costs for them are so prohibitive that the healthcare system cannot tolerate it. So by and large, we are using drugs essentially unchanged for many years, still trying to get control with those same drugs, recognizing, of course, the other parallel factors that are needed beyond pharmacotherapy. The undiagnosed patient is quite worrying, as all of us know in clinical practice, the symptoms of hyperglycemia that we were told in medical school are quite uncommon, and very few patients come in seeing the P's, if you wish, and you're prompted to do some sort of urinalysis or blood sugar in the office. So I encourage, physicians, not just primary care physicians, but almost all physicians in any environment, you should get in the habit of doing a glucometer assessment as part of your routine assessment. You'll be quite surprised of how many patients have asymptomatic hyperglycemia in the office and they came for something else. And this is across the board. This should be in the surgical specialties as well, not the primary care, the cardiology and endocrinology environments. We have a lot better pickup if you do better screening in an easier way to do that. Again, education is better. There are a lot of health fairs, there are a lot of church fairs, there are a lot of health programs that pop up during the course of the year. That has helped quite a bit as well. But we're still seeing a lot of patients that are undiagnosed. And again, in clinical practice, we've seen this. People come in with quite high glycemic parameters, you do a baseline A1C, and the A1C is 11 and 12. Again, representing quite terrible control, if you think about it. And therefore, at that point, we're looking and expecting to find end organ damage already, when this patient is essentially asymptomatic. So we're seeing a patient coming to us, newly diagnosed, but almost in the middle of the spectrum already, in terms of morbidity, unfortunately. So again, proactive screening, just like we check a blood pressure, a blood sugar is actually, I think, a vital sign personally. So I think it should be done as part of routine practice in any healthcare environment. Now, part of the universal problem with diabetes is, of course, compliance and adherence to care. One might say, well, oral therapy is not that difficult to comply with, so it's probably more difficult with injectable therapy. But we know that's not true. Any oral therapy is the same sort of limitation. Of course, drug design, thankfully, has evolved over the decades, where many pharmacotherapy agents are once daily now compared to 2 and 3 times daily. A lot of them don't have the rigidity of nocturnal dosing or particularly preprandial dosing as well. So we are, thankfully, as physicians, able to use therapies that are easier to manage. And again, we need to discuss that as part of our patient's plan. I found in clinical practice it's very useful to ask patients a question, when do you think you could take your medications? As opposed you're saying, we'll try to time it at 11 o'clock in the morning before you have lunch. They'll practically, I will doc, that never is going to work out because I don't have lunch at that time. Or I'm on the road and my job involves me ducking in to buy a sandwich while I'm driving. So work with the patient, come up with plans, and hopefully on an individual basis and then on a population basis, we can get better compliance. This zigzag really says that we have a lot of variability. Again, it's a little hard to read this bottom part of the slide here. So we see here, right, so the top 3 are Barbados, Guyana, and Trinidad with better adherence. And we have Montserrat, Turks, Caicos, and Haiti, relatively low here. So of course that varies, but the reality is that there's a lot of heterogeneity in adherence within the population. And of course, depending on which territory you are, we will understand little nuances of how we get our patients better educated. So what we will try to do to educate patients in Trinidad and might be successful might be very different to what you might do in the Dutch population, the French population, or the Guyanese or the Jamaican population. So again, it is uniquely different, but again, this translates to control. The factors affecting the Caribbean, although we speak about them, they're not unique to the Caribbean. The reality is that the factors of global control are universal. They might have little differences in different parts of the territory, but it is the same thing. Cost is a humongous issue with chronic disease as a whole. And if you can't have access to simple drugs, which is what is categorized by the WHO, then that's a big issue. So although as physicians we read and see a lot of new things coming out in literature, it's very difficult for healthcare system to put resources into that, and we forget the bread and butter, if you wish, essentially. So access is a humongous issue, and again, it varies from territory to territory, but a lot of the English-speaking Caribbean at least, and I think the Dutch Antilles and French Antilles as well, healthcare is quite accessible if you think about it, So one could argue about the waiting times and the number of patients that one has to be seen and the delays in clinic, but you can walk into a clinic and you can't get healthcare. So really, it's proactively pushing the population to seek healthcare initiative and not waiting for them to be unwell. The control of diabetes is universally poor, unfortunately, and this is not any different in the Caribbean. This number is quoted to the North American information from the IDF Atlas, and they quote here as much as 70% of the population of diabetics who are being assessed and medically managed have A1Cs above 7. Again, that's bad control. If anybody thinks about that in their own practice, in their own clinic, that's a worrisome number. That's 2/3 of your patient, you as a physician, as a nurse practitioner, as a dietitian, as a healthcare team, something is missing. And therefore the patient is missing your point, or the healthcare system is not working for them, or they're completely ambivalent and just don't care about their health. But again, it's easier said than done, but the reality is that universal control is poor, and probably the best control is beyond a very niched couple of countries, but worldwide diabetes control is quite difficult. This is a quite well documented fact that glycemic control is strongly correlated with cardiovascular morbidity and mortality. So not just the initial teaching that you get a lot of reduction in events in microvascular disease with A1C improvement, we've now seen that actually is not completely true. You can reduce micro and macrovascular events with glycemic control. This is, again, regional data specifically, and it basically highlights, again, the modifiable and the most counting in terms of factors towards cardiovascular events is high blood pressure, diabetes, and lipid control, which, again, are the same things all over the world. So we're not anything different. So we're not third world in that sense. We have first world disease, and therefore we need to target it aggressively. As a correlate, if you have high prevalence, poorly controlled, you're going to have more morbidity. If you talk to the regional nephrologists, the bulk of their patients coming for dialysis dependency are the diabetic hypertensive patients. And we're seeing younger population of patients. I remember hearing two of the nephrologists speak both in Jamaica and in Trinidad, and they're seeing people mostly in their 50s and their 60s now. So this is not an aged disease. In cardiovascular disease, it's across the board. We're seeing coronary disease in patients in the late 30s and the early 40s quite well. And again, they survive, but they now have advanced heart failure. They have ongoing refractory angina. So their functional capacity is significantly affected. So essentially, you have a minimally functional person at a young age. And of course, that has ramifications as we go along. This is not to downplay retinopathy and neuropathy, but also affects the mobility, of course. So in conclusion, again, this is trying to focus on our environment in the Caribbean and Latin America. We have a quite prevalent disease in terms of diabetes, with the expectation of a significant rise over the next decade. A lot of our patients are not well controlled. A lot of our patients will have cardiovascular disease and therefore contribute to morbidity and mortality. So I will now hand over to Professor Wright, who will take us into the more direct management of diabetes. Thanks, and we'll defer any questions to the end of our board presentations.
Thank you, Dr. Duque. I think we have a lot of questions, and at the end of this session, we will have the opportunity to answer. For those who are online, please try if you can chat, yes, through the web and send the questions, and we will try to answer all the questions. And now, for this, it's a pleasure for me to say and to invite Professor Rosemary Wright-Pascoe to the stage. Yes, Dr. Professor Rosemary Pascoe, she's a Bachelor of Surgery and Doctor in Medicine, Internal Medicine, yes, from the University of the West Indies in Mona, Professor of Medicine and Endocrinology at the University of the West Indian in Mona, and a member of the Board of International Advisory Network of the Journal of the Royal College of Physicians. So, Professor Rosemary, the floor is yours. Thank you.
Thank you so much for that warm welcome. I really am pleased to be here, and I would like to offer congratulations to SERVIER for having this SERVIER Academy for diabetes across Central America and the Caribbean. And this is the title of my presentation that I'll be doing. And of course, how to achieve a complete and early approach to patients with type 2 diabetes. And there are no to discuss at this point in time. Now, when we have a patient with diabetes, we have to treat them both non-pharmacologically in terms of nutrition and physical activity, as well as pharmacologically. And this is a multidisciplinary team that is managing your patients. And in this presentation, I hope to discuss pathways to optimize metabolic control in your patients with type 2 diabetes, and I hope to demonstrate why early and sustained metabolic control is important. Because diabetes, as you know, is a multi-system disorder that has the common denominator of hyperglycemia, but there are many pathophysiological mechanisms taking place here. So you have your metabolic factors that are modifiable, such as body weight, level of physical activity, smoking, heavy alcohol consumption. But you also have non-modifiable factors, such as your genetic predisposition. And there is gene-environment interaction, epigenetics, as well as gestational diabetes. And what you certainly have, if you have a negative risk profile, is that you have beta cell dysfunction and you have insulin resistance. And that insulin resistance causes your insulin-mediated glucose production at the liver to be increased, thus causing hyperglycemia. Their insulin-mediated glucose uptake at the adipose tissues and at the skeletal muscles is reduced, thus hyperglycemia in your patients. And this hyperglycemia, this sustained hyperglycemia, produces endothelial dysfunction. Endothelial dysfunction that is the basis for the micro and macrovascular complications of type 2 diabetes, where you have your inflammatory process taking place, which contributes to the insulin resistance, where the insulin resistance causes endothelial dysfunction, and they feed on each other, and the endothelium is going to be damaged with advanced atherosclerosis, which is a common thing in type 2 diabetes. But in addition, the insulin resistance itself, promoted by the diabetes, obesity, and dyslipidemia and hypertension, thus increasing your patient's risk for cardiovascular disease. Let's talk about Marvin. Marvin is a 62-year-old male who went to the emergency room because he had been experiencing chest pain for the last 1 hour. He noted that the chest pain did not get better with rest and in fact did not improve with analgesics. But on further inquiry, we noticed that he's had prediabetes for some 6 years prior to this presentation, that he was treated with diet and metformin. And in addition, he had had pancreatitis some 3 years ago, and he's had 2 episodes. So the important thing in his past medical history is that he had a parent and a sibling, the family history, a parent and a sibling with type 2 diabetes. We examined him, and his BMI was high at 32, his blood pressure was high at 130/90, and his heart rate was high at 109 beats per minute. On examination of the fundus, we saw that he had severe non-proliferative diabetic retinopathy. Examination of the cardiovascular system, we noted that his pulse was regular, S1 and S2 were heard, there were no murmurs, the JVP was not elevated. Examination of the respiratory system revealed that the chest was really clinically clear. The examination of the abdomen revealed that his abdomen was obese, non-tender, no organomegaly, with a liver span of 11 centimeters. His peripheral pulses were normal. There was no peripheral pitting edema seen. And this is just to remind you how important it is for you to look at the diabetic retina, and you're seeing here the dot and blot hemorrhages, the soft exudates and the hard exudates that you can see, as well as the macular edema that this patient has. So here is our patient now. We're doing some investigations. We see that he has microalbuminuria, 450 milligrams per gram, where the normal is supposed to be 30 milligrams per gram. His hemoglobin A1C is elevated at 9.6%. His random glucose is elevated at 12.2 millimoles per liter. His creatinine is 1.3 milligrams per deciliter, but his EGFR is reduced at 59. His total cholesterol is elevated at 243 milligrams per deciliter. His HDL cholesterol is reduced at 24 milligrams per deciliter, and his LDL cholesterol is also elevated, as is the triglyceride. And we see that on the ECG, he has a sinus tachycardia, but when you look in V2, V3, V4, and V5, you see the ST segment depression that this patient has, suggesting that he has an anterior apical ischemic event. What is your working diagnosis? And I am willing to hear from the audience here, your list, your problem list, diagnosis. In the interest of time, does he have diabetes, or does he still have pre-diabetes? So let us go back to his results. A hemoglobin A1C of 9.6% is certainly greater than 6.5%. If this hemoglobin A1C is used, using the diabetes control and complications trial methodology, this is consistent with the diagnosis of diabetes. A random glucose of 12.2 is greater than the usual 11.1, which is consistent with the diagnosis of diabetes in the presence of polyuria and other symptoms suggestive of diabetes. So I think that he is no longer pre-diabetic. He is now a diabetic. He does have the dyslipidemia, he does have unstable angina, he does have severe preproliferative diabetic retinopathy, and he has diabetic nephropathy. And of course, he is also obese. Now, I tell my students and my residents all the time that obesity is an illness. It must be listed as a problem and it must be addressed when you're managing your patients with diabetes. Now, what point does endothelial dysfunction begin? Because if you were to Google pre-diabetes and cardiovascular risk, you would get more than 4.9 million results, because this is an area that is actively being researched. And so we now know that microvascular and endothelial dysfunction occurs in prediabetes. We've always been told to expect macrovascular complications. We now know that microvascular complications can be seen in these patients. So how can we at the bedside see this microvascular complications? Certainly, if you look at the retina, and you can do the retina by doing a retinal photography, and I hope by now most of the regions are doing retinal photography to screen for diabetic retinopathy. Quite a significant way of determining that. This is a way for you to see the retinal microvasculature. Again, for the renal microvascular injury, a simple urinary albumin excretion is an index of renal glomerular dysfunction. Now, there are a wide variety of other things here, but in the interest of time, I'll move on. So what does this gentleman have? He has hyperglycemia. He has microangiopathy. At the level of the eye, he has a retinopathy. He has diabetic macular edema, which of course is the commonest cause of blindness in type 2 diabetes. So he is at risk for blindness. He has kidney involvement. He has albuminuria. He has a reduction in his EGFR. He is at risk for end-stage renal disease. Now, we never heard about his neurological examination, but sensory and motor neuropathy is one of the commonest complications of type 2 diabetes at the time of diagnosis. So we know that he's probably going to be at risk for foot ulcer, and if he has autonomic neuropathy, he's going to be at risk for sudden death. We know that he has heart involvement with a demand-supply mismatch, which is the cause for his angina, but he doesn't have heart failure at this point in time. With regards to the brain, we know that there is blood-brain barrier alterations, and many of you might have been seeing that when you order an MRI brain on your patients, many of them have white matter lesions, and these is a risk factor for the development of dementia that we see in diabetes. The stiffness occurs in the vessels, and his blood pressure was high, and plaque formation also occurs in the vessels, and if they rupture, then he is at risk for sudden death. Now, the bone marrow, also there's reduced endothelial progenitor cells, which causes impaired vascular healing. We know that there's a common etiology between hyperglycemia and vascular disease, and that is endothelial damage. With hyperglycemia, you have advanced glycation products, which then create problems with protein kinase, create problems with reactive oxidation species, have problems with increased apoptosis, and all of these affect the endothelium, resulting in an inflammation of the endothelium, the production of angiogenesis with new vessel formation. You have problems with your hyperpermeability at the level of the kidneys, and of course, it is a prothrombotic disorder. These patients will have thrombotic disorders because of the changes that take place in the presence of hyperglycemia. So hemoglobin A1C is a marker of endothelial dysfunction in your patients with diabetes, an independent factor, and it triggers the atherosclerosis, causing the cardiovascular events and the retinopathy. So, how prevalent are the complications of micro and macrovascular disorders in patients with type 2 diabetes? They're quite prevalent. This is a study from the United States looking at newly diagnosed diabetes diagnosed within the previous 2 years. And you're looking at chronic kidney disease, albuminuria, and the prevalence on the y-axis. And you can see 25% of patients have chronic kidney disease, 18% albuminuria, and a whopping 10% already have a reduced eGFR and therefore are at risk for the development of end-stage renal disease. 12% of them already have retinopathy, and 16% of them report having cardiovascular disease. And when you dissect that further, 5% have a history of congestive heart failure, 60.4% a history of stroke, and 10% have a history of heart attacks. So there are complications. Chronic complications of diabetes are already highly prevalent in your newly diagnosed diabetic. And we know that hyperglycemia is closely related to endothelial damage. But why is that so in pre-diabetes or very early diabetes? This is coming from the United Kingdom prospective diabetes study, and there are two graphs. One looks at myocardial infarction, the other one is looking at microvascular endpoints, and we're looking at correlating that with hemoglobin A1C. Now, we have a hemoglobin A1C here of 5.5%. But myocardial infarction rate is not 0, and microvascular endpoints is not 0, so that you know that in your pre-diabetic individual, they are at risk for macrovascular and microvascular events. Just as how hemoglobin A1C excess causes macrovascular and microvascular complications, the reverse holds. If you can lower the hemoglobin A1C, you can reduce the risk of developing these events in a proportional manner. So, Mr. Marvin, the question that we must ask ourselves is, if we had been more aggressive, could we have been able to avoid the complications of diabetes? Well, we have him now, and we already know that if we lower the hemoglobin A1C by 1%, that we will reduce any diabetes-related endpoint, any diabetes-related death by 21%. If we can reduce the hemoglobin A1C by just 1%, we will reduce his risk for myocardial infarction and all-cause mortality and stroke by 12 to 14%. For every 1% reduction in hemoglobin A1C, you reduce the relative risk of peripheral vascular disease by 43%, microvascular disease by 37%, and cataract extraction by 19%. So armed with this information, we are going to go out there and tightly control our patients so that they, in fact, can be prevented from having the chronic complications of diabetes. I want to talk a little bit about the legacy effect, or metabolic memory, which is that when you tightly control persons with type 2 diabetes at the time of the diagnosis, and you are reducing their risk for the chronic complications of diabetes, 10 years later, when they're no longer tightly controlled, your cells have metabolic memory and they still retain reduced risk of these chronic complications simply because 10 years previously you had tightly controlled them. And of course, we know straight off that the Diabetes Control and Complications Trial, the United Kingdom Prospective Diabetes Trial, told us that if we want to avoid the complications of diabetes, if we want to delay the progression of the chronic complications of diabetes, we've got to control our patients. So this is from the United Kingdom Prospective Diabetes Study, and here we're looking at all-cause mortality and myocardial infarction. We have two sets of patients. Those who from the time of diagnosis were tightly controlled. The other set of patients had delayed control. It took some 10 years after diagnosis before they were controlled. 10 to 15 years later, these persons who were tightly controlled at the time of diagnosis continue to benefit from a risk reduction in all-cause mortality, in myocardial infarction by 18 to 20%. The individuals who were not controlled, where control was delayed, only benefited from this reduction by 2.7% and 6.5%. Again, reminding us that the patient in front of us who's newly diagnosed, you are to get them to target as quickly as you can, and you are to maintain the target. Because if you can detect the diabetes early, if you can control the glucose as best as you can reduce long-term risk of glycemic controls. So here's Marvin. He has hyperglycemia, he has diabetic retinopathy, he has diabetic kidney disease, and he has cardiovascular disease. So I don't know, are we going to throw up our hands in the air? We are not. We know that 50% of patients with type 2 diabetes have chronic kidney disease. So you've got to deal with it, okay? And we know that 30% of patients newly diagnosed with type 2 diabetes may, in fact, have the symptoms of diabetic kidney disease even before type 2 diabetes is diagnosed. So what are we going to do? Every new patient that we see, we are going to evaluate their renal status by looking at their kidney function, looking at their EGFRs. We want their EGFRs to be greater than 60 mils per minute per 1.73 meters squared. And I'm asking you to insist that your laboratories actually give you the actual value of the EGFR and not just simply tell you that the EGFR is greater than 60 or less than 60. You want to look at kidney damage also by calculating the urinary albumin-creatinine ratio. So check for albuminuria, and clearly, if they have albuminuria, you'll be doing a urine analysis, looking at the urinary sediment. You'll be looking at the electrolytes. You'll be looking at an ultrasound of the KUB ultrasound, and if necessary, you might want to refer this patient to the nephrology team for them to or not do a renal biopsy. This is a guide that tells us how often we should be screening our patients. So if your G1, your GFR is normal, okay, and your albumin excretion is normal, then you can do an analysis of their renal status once a year. If their A2 and their albumin the albumin excretion is greater than 300 milligrams per grams, even here, they are at risk for rapid reduction in their EGFR, so you should be evaluating them twice a year. For the mildly decreased one, again, it depends on what the level of albumin excretion is, because albumin excretion worsens prognosis and accelerates the development of end-stage renal disease. Once your patient reads a G3B and they have mild, moderate albuminuria, you should be seeing and evaluating them 3 times a year or 4 times a year. And our patient was at stage G3A3. Now, let us recognize that patients who have chronic kidney disease need to have adequate hemoglobin A1C control. So in this study where you're looking at the adjusted risk of adverse events in people with stage 3 chronic kidney disease by A1C levels, there are 3 categories of patients here. There are patients whose hemoglobin A1C is less than 7%, represented by this blue. Those whose hemoglobin A1C are 7 to 9%, represented by the pink, and those whose hemoglobin A1Cs are greater than 9%. Look at the relative risk of all-cause mortality, a whopping 35%, just simply because your hemoglobin A1C is greater than 9%. In terms of acute all-cause hospitalization, 44%, myocardial infarction, 85%, stroke, 96% increase, heart failure, 89% increase, and end-stage renal disease, 152% increase. So the moral of the story is, in the patient with diabetic kidney disease, you should still opt for them to be well controlled and to be at a hemoglobin A1C of less than 7%, thereby reducing their risk. So the fact of the matter is, they can progress to chronic kidney disease to requiring dialysis or even kidney transplantation. Fact of the matter is that they will die 90% of the times, not from end-stage renal disease, but from cardiovascular disease and infection. So you're duty-bound to prevent this from happening. Right at this point in time, it is considered that we need to detect diabetic kidney disease early to reduce the complications, the morbidity, and the mortality. And we should refer our patients to a nephrology service once the eGFR falls below 30 mils per minute, or once the albuminuria exceeds 300 milligrams per gram. But remember that by the time you're referring them to nephrologists, they've already lost 70% of their renal function. I want to introduce you to this concept of the cardiovascular kidney metabolic health, where if you have no risk factors, you're stage 0. But by the time you have adiposity, whether you have abdominal obesity or generalized obesity and impaired glucose tolerance, you're stage 1, cardiovascular kidney metabolic syndrome. You go on to stage 2 when you now develop hypertension or hypertriglyceridemia or type 2 diabetes, or you now have moderate or high risk for chronic kidney disease. You move on to stage 3, and here you have subclinical cardiovascular disease, either subclinical heart failure or subclinical atherosclerotic cardiovascular disease. On stage 4, of course, you now have clinical chronic kidney disease as well as critical cardiovascular disease. You have peripheral arterial disease, you've had a stroke, or you have atrial fibrillation, or you have heart failure. The Diabetes Control and Complications trial changed how we manage patients with type 1 diabetes. Our focus now was on preventing chronic complications, and we used driving the glucose down to target hemoglobin A1C to help these patients. And by doing that, acute myocardial infarction, stroke, amputation, and end-stage renal disease fell quite significantly. Death from hypoglycemic crisis fell as well. But you must note that that was in the past. We're moving on into the future. There are other parameters of glycemic control that we should now be looking on. So here is a patient with continuous glucose monitoring whose hemoglobin A1C, the target is supposed to be 7%. This patient's target is 6.7%. And normally, you'd pat yourself on the back. I've done my work. Patient is well controlled. I've protected my patient from chronic complications. We also looked at the glucose monitor results. You know, you can check the 7-day average, the 21-day average, the 14-day average, the 28-day average, and you're pleased with yourself. The average works out to 135 milligrams per deciliter. Again, this is within the therapeutic range. What you have not done is you have not looked at the glycemic variability, because glycemic variability is now the new hot potato in endocrinology. See, this glycemic variability was supposed to be less than 50 milligrams per deciliter, and here the patient's glycemic variability is 75 milligrams. Now, what does that all mean? Just look at it. His glucose goes as high as 300 milligrams per deciliter. 300. 300, 300, 300, 300, 300. He has episodes of hypoglycemia going all the way down. So he is varying his glucose quite rapidly, and that is an independent risk factor for cardiovascular disease. So yeah, we're going to continue looking at fasting glucose. We're going to continue looking at total postprandial glucose. We're going to continue to look at hemoglobin A1C, but you need to know that we are now talking about time in range and glycemic variability. So glycemic variability is an important concept. Here you have 3 individuals. All of them have a hemoglobin A1C of 7%. But individual 1, when you look, time spent in the hyperglycemic range is pretty significant. Time spent in the hypoglycemic range is pretty significant. Time spent in range is not sufficient. So when you look at it, 58% of the time, your patient is in the hyperglycemic range. 24% of the time, the patient is in the hypoglycemic range. And this high variability with dangerous highs and lows is a risk factor for cardiovascular mortality. Look at patient number 2. 63% of the times he is in range. 29% of the times he's hyperglycemic. 8% of the time he's hypoglycemic. So he has moderate variability and fewer highs and lows. Patient number 3 is the one who should get the gold medal, because patient number 3, 100% of the times, has little variability, and all of his time is time spent in range. So these 2 individuals, Joseph and John, have the same hemoglobin A1Cs. You look at the mean glucose looks the same, but their standard deviation is different. One is having significant glycemic variability compared to the other. Does it matter? It does. Does it matter to those of us who are not managing patients with continuous glucose monitoring? It does, because you can look at your fasting glucose, which you should be telling your patients to do, and they should be bringing the values to you for you to look at it. Because fasting glucose here, we're looking at our all-cause mortality, and we're looking at 3 categories of individuals. The red category are individuals whose glucose doesn't vary by more than 14 milligrams per deciliter. The blue are individuals whose glucose varies between 14 and 25 milligrams per deciliter. The green are those whose glucose varies by more than 25. And you can see that if your glucose is not varying very highly, you are more likely to be alive 6 years later than the individual whose glucose is varying very rapidly with glycemic variability. Their mortality is increased. And the same holds for all-cause mortality and cardiovascular mortality. So time in range is a big thing now. It indicates the percentage of how long your patient's glucose value is within the target range that you have decided that they should be in, and the duration of time that you have decided that they should be at. This is another study from the Diabetes Control and Complications trial, and they chose to calculate time in range at 3.9 to 10 millimoles per liter. And they noticed that it was associated not only with proliferative diabetic retinopathy, but also with microalbuminuria. And so they pointed out that with every 10% reduction of time in range where you should be, there was an increase in risk of diabetic retinopathy by 64%, microalbuminuria by 40%, and peripheral neuropathy by 25%. So we have our patient. We are going to manage his dyslipidemia, treat his acute coronary disease, and use antiplatelet agents and so on. What else are we going to do for our patient? He's hyperglycemic, okay? Should we increase his metformin? Should we add an SGLT2 inhibitor? Well, I want to talk about reducing hyperglycemia and compare that with SGLT2 inhibitors and glycoside MR. The patient cannot get GLP-1 receptor analog because he had previous pancreatitis. You could give him insulin, but of course we do have an insulin-phobic community, people in the Caribbean, but you can try and convince him to go on insulin. And of course, if he does not wish to stay on insulin, you can also switch him to a 3rd-generation sulfonylurea. Let us recognize that there is a significant concern about the management of chronic kidney disease. First of all, the diagnosis of it and the management of it. And you really need to spend a lot of time to use drugs that have a mechanism of action that is renal, and drugs which have cardio and are nephroprotective drugs. So when you talk about the sulfonylureas, the first thing that comes to your mind is, but isn't it going to cause hypoglycemia? Well, we are seeing here that the drugs, drugs that have renally excreted active metabolites, such as glibenclamide and glimepiride, are the ones that are associated with hypoglycemia. when you have drugs that are unchanged or they have inactive renal metabolites with minimal hypoglycemic effect, they are not associated with hypoglycemia. One such drug is glycoside and glipizide and tolbutamide. Because glycoside, of course, is a third generation sulfonylurea, a long-acting drug with a time to peak plasma level of 67 hours. It's renally metabolized most of the times, at fecal metabolism 10 to 2% of the time. It does not have any active metabolites, and therefore no dose modification is needed in patients with renal dysfunction. Now, is this an efficacious drug? We're looking at patients here, some 7,000 patients, who came in with hemoglobin A1Cs of 8.3%. They were titrated with glycoside, starting at 30 milligrams. And you can see that at the end of the study, the hemoglobin A1C had fallen by 1.6%. You have another category of individuals with a hemoglobin A1C of 9.2. At the end of the study, the hemoglobin A1C had fallen by 1.9%. So progressive glycoside MR up-titration was well tolerated in these patients without hypoglycemia and utilizing a different and many other glucose-lowering therapy. What about glycoside and sitagliptin? How do they compare? This is a head-to-head study looking at glycoside MR and comparing it with sitagliptin. You have two categories of patients: those who have a hemoglobin A1C less than 7%, that's the target, and the other target, and we see that 35% of them were more likely, those on glycoside MR, to achieve that target hemoglobin A1C. The other category of persons were given a target hemoglobin A1C of less than 6.5%. And at the end of the study, 51% of those on glycoside MR were more likely to achieve this target hemoglobin A1C. And this is a durable drug, a persistent drug, and there are low rates of hypoglycemic events. We know that from the advanced trial that glycoside MR, when compared with the intensive therapy, with glycoside MR compared with the standard therapy, that glycoside MR reduces new onset of microalbuminuria by 9%, new and worsening nephropathy by 21%, new onset of macroalbuminuria by 30%, and a whopping 65% reduction in end-stage renal disease. So, colleagues, at last, just to summarize, patients with prediabetes are at risk for microangiopathy. You need to make the diagnosis and you need to screen them for it and treat them for it. Diabetic kidney disease is not uncommon. It's common in your general population of diabetics. Cardiovascular disease is not uncommon in your patients. You've got to look for it, and you need to look for the cardiovascular kidney metabolic syndrome. You need to aggressively control hyperglycemia. You need to control hyperglycemia as early as you can so that you can reduce the risk of morbidity and mortality in your patient. And so that with the legacy effect, years later, even when they're not controlled, they will be benefiting from the previous times when they were controlled. You're going to use your hemoglobin A1C as before, but you need to also consider glycemic variability, which is a doable thing in your general practices, and you need to also consider time in range, and you can actually do time in range if you have your patients look at their glucose in the different parameters: fasting, postprandial breakfast, postprandial lunch, postprandial dinner. But for those of you who have patients on continuous glucose monitoring, you can see what percentage of time they are spending in time in range. You want to use drugs that are going to reduce the progression of cardiovascular disease, such as metformin, renal and cardiovascular disease, such as the SGLT2 inhibitors, the GLP-1 receptor analog, and the sulfonylurea glycoside. Glycoside has minimal hypoglycemic effect, is well tolerated, safe, gets your patients to target, and you can use it in a wide variety of patients with different glycemic levels, different age, race, obesity, those with and without cardiovascular disease or renal disease. And I thank you so much for your attention. Thank you.
Right, so very excellent lecture, of course. I think hopefully everybody's hearing us online as well. So floor is open for questions. While you guys think, I will get the ball rolling. So pre-diabetes and 500 milligrams of metformin. What are your thoughts? If you make a decision on pre-diabetes treatment, that's not effective therapy.
Actually, I reviewed a study recently that has documented that prediabetes can be treated with as low a dose of metformin as 250 milligrams. My policy is 850 milligrams twice a day. That's what I'm aiming for. But it seems that even persons who can't tolerate that dose will benefit from progression to type 2 diabetes.
So the protocol you're suggesting, if memory serves, was from the diabetes prevention protocol. I always had this paradox talking to patients about this. So, you're telling them they're pre-diabetic, you're putting them on a drug, 850 twice a day is treating, basically. And of course, we get this flip now. Well, we pre the A1C, and it's still 6.1. Well, doc, it didn't move. Yeah, but you didn't go forward. So again, what are your thoughts in terms of that decision? Is it that you keeping them where you are, or actually should you try for tighter control once you've labeled them as prediabetes?
I think we have to remember that that study had demonstrated that metformin was inferior to intensive lifestyle modification. But that intensive lifestyle modification is not the one that we do, which is piece of paper, go exercise, and here's a diet sheet. That doesn't work. So if you're going to do intensive lifestyle therapy, you're talking about patients having discussions with a group that is motivating them on a regular basis. They are assigned exercise physiologists who are there with them. They are allowed to learn about behavioral modification. It's quite an intensive thing that you are doing. Now, what is happening in the United States is that they are offering these community tight modification and change in exercise behavior, sedentary behavior, and diet. And you can get this protocol from the United States, and you can try to institute it in your patients. That is a better way of preventing type 2 diabetes than just with drugs. That methodology reduces the risk of progression to type 2 diabetes by around 30%, whereas the metformin reduces it by around 25% or so. So we know that metformin is not the be-all and the end-all. It must be associated with exercise, weight loss.
Questions, yes. Try to use the mic if possible to remember our audience online as well as listening.
Right. HbA1c seems to be the parameter to determine complications and the outcome. Now, the figure of 7% pops up very often, but so does 6.5%. The question is, should we shift the goalposts from 7 to 6.5?
Excellent question.
Yeah.
Are you all hearing me? Okay, excellent question. You know, the decision as to what target you're aiming for is an individualized one. You are there with the patient, you sit with the patient, and you analyze your patient. If you're looking at an 84-year-old man who is bedridden, why would you be aiming for tight glycemic control? The quality of his life is such that you are not going to prevent chronic complications of diabetes because his expected lifespan is significantly reduced. So you're not looking for tight glycemic control in an 84-year-old. You may do tight glycemic control in a 70-odd-year-old person because generally speaking, on average, people are living up to age 84, 85. You don't want to do tight glycemic control in somebody who has multiple cardiovascular risk factors, because the study was done and they died more so when they were tightly controlled as opposed to when they were not tightly controlled, and this was not related to hypoglycemia. So 6.5% or less is for a young person, a middle-aged person, somebody who is 65 and over, who doesn't have many multiple risk factors for cardiovascular disease. Excellent. 7% or less is for the person in the middle, and 8% and above, or less than 8%, for the very elderly, frail patients, because you don't want to precipitate hypoglycemia and increase cardiovascular morbidity in that group and mortality.
So I guess the glycemic variability would be the more useful thing rather than shifting the goalposts.
Well, I think glycemic variability is a new concept. But again, the concept of preventing complications depends on the individual in front of you and the expected lifespan of that individual. Again, and the quality of life of that individual. The patient who is bedbound, you know, who's very advanced in his age, it's not a person that you want to worry about time in range and glycemic variability. You want to do that for your young, your middle-aged, and your early elderly persons.
Just to kind of throw in about the CGM, of course, it's not something readily available for most of us. In Trinidad, for example, somebody was offering it privately, but it's no longer available. So we do have the occasional patient who gets the Libre from the States and uses it, but in practicality, we don't have that, and this probably applies to most of the Caribbean. A simple thing I found is, other than telling them to check it different times, a lot of the phones have the apps. You literally plug in the numbers, and it's dumb-proof. Just say, well, export it to me when you're coming, or print it if possible. And it gives you the calculations. So it actually gives you the average for the month. And some patients, of course, very high-tech, it's like an Excel sheet and all the excitement. But the app is actually built in. We use this a lot for our hypertensive patients as well. Literally tell them almost do like randoms. Don't only do mornings when you wake up. And we get the same sort of information for our blood pressure. So we get analogous to a 24 BP type of information. We're just going to jump to one of the online questions. And I have a group of diabetic patients who are on adequate therapy and remain controlled, but constantly suffer from nausea and vertigo. Is this likely from diabetic nephropathy? And what treatment do you suggest? So, clinical question.
So you have individuals who have diabetes. They're well controlled, and they're having nausea and they're having vertigo. Well, you know that you need to screen these individuals to see if they have autonomic neuropathy, which is what I think you're asking. So individuals who have autonomic neuropathy can have cardiac autonomic neuropathy, and those individuals, their R-to-R variability in terms of exercise is pretty standard. They may have a persistent tachycardia, for instance. Then, of course, you want to have a look to see if they're having postural hypertension, what is the blood pressure like, supine and erect, to see if they're unable to maintain their blood pressure because of autonomic neuropathy. You may be able to see if they have gastrointestinal autonomic neuropathy with nausea, persistent vomiting, with gastroparesis, or even just diarrhea that they may have which tends to be at bedtime, or constipation. So I think that in terms of autonomic neuropathy, you can refer these patients to the cardiology team. You will tell them what you do.
So of course it depends on what the patient presents with. So many times we refer the patient who has an inappropriate sinus tachycardia, and we look for certain types of things. So again, then we ask about orthostatic symptoms, whether we do a tilt table test. Again, simple questions can direct you if you have neuropathy, peripheral neuropathy, if you have some symptoms of gastroparesis suggesting other autonomic dysfunction sites, that helps as well. But a lot of it, again, boils down to treating what's in front of you. If they're orthostatic, you discuss anti-orthostatic measures, and if very symptomatic, you would treat that with different drugs to raise blood pressure. If the tachycardic, of course, sometimes the only end result is a 3D tachycardia. Again, trying to choose agents that will not be in of themselves hypertensive in nature. So it really depends on the patient who's in front of you and what they're just talking. And we talk about this automatic neuropathy in a very broad sense, but it really hits a lot of organ systems. So you really have to think in the back of in your brain of what's happening. I've seen very bad diabetic diarrhea, for example, and it's sometimes almost refractory. And again, we think of it as, okay, well, this gastroparesis, but no, the large bowel is affected as well. We just have one more question for now, and then we'll proceed to the clinical cases. Dr. Bukaj?
Right. Marvin was an interesting diabetic, but he was also hypertensive. But his blood pressure is also well chosen, 130/90. Is there any benefit to addressing a man with a blood pressure of 130/90, as was the case in Marvin there?
The United Kingdom prospective diabetes study was a marvelous study because we learned a lot about type 2 diabetes. And one of the things that we learned was that control of blood pressure is the most important thing for the type 2 diabetic. It is associated with significant reduction in macrovascular complications, including heart disease, heart failure, etc., peripheral arterial disease, etc., and reduction in mortality and morbidity. So you absolutely must be meticulous with the blood pressure control of your diabetic. A 130/90 is not normal. I try to remind my patients of that. They always tell me, but you know, I was rushing when I came here, and I said, okay, go outside and let's rest. Come back in and I repeat the blood pressure is 150/101. Oh, but when I come in here, I have white coat hypertension. White coat hypertension is also a risk factor for cardiovascular events. So you must be very meticulous and control your blood pressures to a systolic of less than 130 and a diastolic less than 80. I don't know what you all think as a cardiologist. Have you all changed the parameters?
So there's a bit of a difference in terms of the diagnostic level with the American and the non-American guidelines, if I use that word. So I guess that makes a little bit of an issue. But funny enough, the goals are the same. So once you've made the diagnosis of hypertension, the 130 systolic and the under 85, ideally under 80 diastolic is preferred. So you're really looking at this patient, panvascularly, both metabolic and blood pressure control. And of course, depending on what morbidity they have, I usually call them hypertensive plus syndromes. So hypertension plus diabetes, you take this drug. Hypertension plus MI, you take this drug. Hypertension plus nephropathy, you take this drug. And of course, it's hypertension plus diabetes plus nephropathy plus heart failure. You have those drugs as well. This is the last question just from one of our online panelists. Interesting question. So a lot of evidence that SGLT2 inhibitors have significant cardiovascular benefit and therefore strongly recommended in most of the guidelines. Why should we keep prescribing an SU like gliclazide?
Yeah, so I believe the question is that the SGLT2 inhibitors have strong evidence of reduction in cardiovascular morbidity and mortality. But even when, the question is why use sulfonylurea, which is inferior with regards to that? But I think I just showed you that in fact gliclazide MR has some reduction in cardiovascular mortality based on the large study that we're going to be presenting as we discuss the next few cases. And it also has a reduction in the chronic kidney disease and reduction in the parameters of kidney disease. So if your patient can afford an SGLT2 inhibitor and they have cardiovascular disease, that's a great thing for you to do, to put them on that. If your patient can't afford an SGLT2 inhibitors, then you have a drug like gliclazide MR. And be very mindful of the fact that not only are you trying to prevent progression of cardiovascular disease and nephropathy, but you also must get your patient to target hemoglobin A1C. And if you can't achieve that alone with an SGLT2 inhibitor or a GLP-1 receptor analog, you've got to add other drugs. And one other drug that you can add is a sulfonylurea called gliclazide MR.
So I would just strongly emphasize that efficacy is quite an important parameter. it makes no sense calling somebody heart failure. You give them an ACE inhibitor, and their blood pressure is still 160/90. Yes, you give them an ACE inhibitor, but the blood pressure is still 160/90. So again, if as part of your armamentarium, let's say the patient has CKD, they've had an MI, they have heart failure, I want to use a SGLT inhibitor, great. And if on that therapy you have A1C that's controlled, great. The reality, that's not the reality in most of our patients. Most of our patients do need add-on therapy. So I would more put it in the context, you shouldn't not use an SU. Don't throw it out of your discussion. It is a quite safe drug, and it's quite well documented. The third generation SUs are quite safe in cardiovascular patients, and to be fair to the data, glycoside does have more information targeting it as a safe drug, especially the advanced trial. If you read the diabetic guidelines, the ADA guidelines, even now, many years later, the advanced trial is strongly always mentioned when talk about SU safety. Right, so thanks everybody for those questions and listening. We're going to cross over to our workshop or case discussion where Prof and I will be discussing 2 cases. Right, so we're going to have discussion in between the cases, but Prof and I are basically going to be juggling between the slides as we talk. So the first case is a 50-year-old male. He's a lawyer, type 2 diabetes for 3 years, and is currently on metformin at target dose, which is 1,000 milligrams twice a day. He is under his care of his primary care physician. It doesn't say how often he attends, but he's under the care basically of a non-specialist. So as mentioned before, diabetes for 3 years. He's also hypertriglyceridemia, and he does mention possible neuropathy symptoms, which is lower limb paresthesia at night. Not exercised, but also stopped sugary drinks in an attempt to be better with his diet. And quite importantly, no history of diabetes in his first-degree relatives. 178 pounds, 130/80, so that magical blood pressure is there. BMI of 27. These will probably be fasting, I think. So a fasting glucose of 187 or 10.4 millimoles, a postprandial of 253 or 14.1 millimoles. A1C, not terrible, 7.9%. And again, bearing in mind this is already on metformin therapy. Creatinine of 0.9, we'll come back to the GFR, but basically that's a normal creatinine range. Albumin-creatinine ratio of 13, which is also in the normal range. And mild dyslipidemia, if I use that terminology, where only really the triglycerides is not ideal at being under 150. The other parameters may be considered quite acceptable. And no obvious evidence of steatohepatitis, which the terminology has changed, which again we should actively be thinking about in our diabetic patients. Fatty liver is quite common. So an AST and an ALT that are normal. So part of our assessment helps decide what we do. So essentially we have a patient in front of us who's not at goal. So the first comment is, well, they're not where they need to be. Now you could say, well, it's 7.9 and I want 7%. Maybe I just emphasize that in exercise, and maybe that's going to be sufficient. So again, that doesn't change what you do. That should be an add-on to what you do. But the patient in front of you, again, you need to decide, what am I going to get this A1C down? So if it's a high-risk patient, we might choose these types of therapies. If it's a low-risk patient, we might choose these type of therapies. So it actually does make a difference. It's not random. Choose a drug because the A1C is 7.9, and as we say jokingly, the flavor of the month. So in terms of the cardiovascular risk, I mean, we know the things that we think about, but again, sometimes weighing them are a bit difficult. So for example, in the Southern Caribbean, Guyana, India, Guyana, Trinidad, and Suriname, where the South Asian population is considered high, again, how much weight do you put on that? Is that doubling the risk? Is that tripling the risk? Is it 1.5 times the risk? Again, age, we talk about age, but if you have a 65-year-old male whose all their relatives died in their 40s, that's a very different thing, as opposed to an 85-year-old male who everybody lived to 100. So again, you have to think of some of these things, although we plug them in. But again, these are the things that we know about. What are the blood pressure? What are the lipids? Are they smoking? What is the activity? And again, probably not calculated, but ethnicity is a relevance factor. So just to kind of put the things in context, most of the scoring systems use these minimal amount of information: age, gender, the presence of diabetes, the blood pressure. Some use systolic and diastolic, some only use systolic, presence of smoking and the absence of smoking. And they usually look at two parameters in the lipid profile, cholesterol and HDL. And again, from that, really what you're getting is a non-HDL parameter, which is here. Part of that reason is hypertriglyceridemia in itself has not been traditionally thought to be an overwhelming driving force for coronary disease. So one of the more popular scoring systems in our part of the world is the ASCVD. And really, it's a revamped version of Framingham, if you think about it. It's really, they've looked at it now a broader population base, and they've recalculated what these different calculations mean. But it's the same parameters that they've used. Whereas Framingham was a biased population, if you wish, in a certain part of North America, and those calculations were always argued, quite rightfully so, can they be extrapolated to a broader population? The thing with scores, and I think it's important to emphasize this, just like guidelines, scores and guidelines, although we use them in our part of the world, they're designed for that part of the world. So the American guidelines are for Americans, the Canadian guidelines are for Canada, and the European guidelines are for Europe. So they're factoring their scoring systems for what's access to care is and what's available. So if you, I don't like the score, but I'll tell you about it. There's the score, which is the European score. And we can't use that in our part of the world because the score, which is the European score, uses country. So they define that these countries are considered high risk, and therefore the population has a different calculation. There's another score for low-risk countries, for example, the Scandinavian countries, and their score has a different weighting. The UK uses something called a Q-risk score, and they have ethnicity, so they would have South Asian, for example, but again, their calculations based on coronary disease and risk factors in their population. So always to bear this in mind, it's a number, but then you have to contextualize it back to our population, which is a different population. The Caribbean, North American black population is not the West African black population. The South Asian Caribbean population is not the same as South Indian in a very technical sense, Indian population. So again, it's contextual, but just always factor that in mind. So with these numbers, we get a calculated parameter of 6.7%, which is elevated, so but not terribly so, but it is an elevated risk. But you sort of knew that, because he's diabetic. He's older. So although he's not smoking and he's not, hypertensive, he does have risk. So I think we're going to have a poll now. Is that the purpose of this slide? Nope. Okay. All right. So the calculation gave us high category. But let's look at some other things that were mentioned, or if you wish, we should have factored in. Duration of diabetes, which is actually quite an important parameter. So the 50-year-old diabetic who's been diabetic since 25 is different to the 50-year-old diabetic who was diagnosed last year. And they could have the same A1C at that point in time. The actual creatinine in these scores are actually not mentioned. So again, this is a patient who has normal renal function. Proteinuria, again, is mentioned or not mentioned. So again, there's some other things that we should be thinking about. So some other scores do take this into consideration. So this is some of the European recommendations, which I've always found easier to read and more practical. So already mentioned the score. They look at a very practical patient in front of you. So age of the population, but again, tying into the duration of diabetes, and the absence of other risk factors. So in other words, he's not hypertensive, he's not obese, he's not smoking. So in this scoring system, he's actually moderate, which is actually quite a fair comment. Again, because your choice of therapies will make a big difference. Not every diabetic needs to be on ACE inhibitor. Not every diabetic probably needs to be on a statin. Definitely not everybody should be on aspirin. So don't throw the carte blanche at everybody just because the definition of diabetes is there. So actually we have two different scores, and that might influence our choice of therapy and also our intensity of therapy. Again, don't downplay the things that we know, but again, difficult to weight. I put a very strong influence on family history. If somebody said their dad had an MI in their 40s, or worse yet, their mom had an MI in their 40s, which is not supposed to happen, that's a significant thing. It means that you have an advanced vascular risk of this patient. Or somebody who had a history of chronic kidney disease needing dialysis and their uncle died at 55. Or their mom had a stroke at her 50s and died at 62. These are real things that you need to factor in. So you will get this number, whatever the number you want, but again, you could minus and add to that usually. I think this ethnicity, as I said, is not something we should underplay. CRP, not a big fan of it, only because it's so non-specific, but the literature does mention, as you know, that if the CRP is elevated, it represents an inflammatory state, which more at risk of plaque rupture, and therefore events. And therefore, if it is elevated, again, that might change your intensity of therapy. Primarily statins that you're looking at here, basically, and maybe choosing antiplatelet therapy. So, as I said before, we have the score, but there are a lot of other things to take into factor in. And I think Prof made a very good point. Write things down in front of you. Not everything you write needs to be dealt with. It's a phased process. So in front of you, you might have a patient who has symptoms of hyperglycemia, and you want to focus on that at the first or second visit. But in your list, you have backup on top, what my BMI was 31. Let's look at that as well. This patient is not active. So are you doing things as best as you can in parallel? There is a hierarchy, clinically. So again, document things. Or I put a note sometimes, at follow-up, I will discuss this. So in the back of your mind, you know you didn't have time to deal with it, but it becomes part of your evaluation. Because at that point, hopefully the A1C part of it is less of a concern, but the other things need to be taken into priority. It is not simplistic to tell patients to lose weight. It is not something easy to do. And just to reinforce that trial that Prof was mentioning, the DPP trial, if you look at the information, it was a very, very structured way they made the patients get better. If you look at it and you read it, it's not practically doable in the average person, far less in the professional person as well. It's a dedicated coach, a dedicated dietitian, working with this person multiple times a week. This is not handling a diet sheet and coming back in 6 months. So again, not to be ignoring the role of that, but be very careful how much you expect to get out of that in a practical sense. I'll hand over to Prof now.
Yeah, so what is the patient's risk for chronic kidney disease? I have this, please. Is it high, very high, or is it moderate? Well, we can calculate his EGFR using two different formulas. You can use the CKD EP1 formula or the MDRD formula, and both formulae have him having a glomerular filtration rate that is greater than 90%. As was said before, his albuminuria is normal, so he is at this level here, in the green level, which is the level that's not associated with a high risk of chronic kidney disease. So the answer here is moderate. Why? We just told you that he has an EGFR that's normal. He doesn't have any microalbuminuria. But you didn't remember that he has a family history of a father who died from end-stage renal disease. And family history of end-stage renal disease is a very strong risk factor for the son developing chronic kidney disease. So that is why we have put him in the moderate risk factor. Well, what is the hemoglobin A1C's goal, which is one of the questions that was mentioned by somebody here in the audience? Should it be 7.5%? Should it be less than 6.5%? Should it be 7%? And we see here that we're suggesting 7%. Now, some of us may argue that he is just 50 years old. He has 40 more years to go. He doesn't have any major kidney disorder at this point in time. He does have mild dyslipidemia, but he doesn't have established cardiovascular disease. And in fact, you might want to consider going down to a 6.5%. And that's a nice thing about choosing a target for your patient. Your target hemoglobin A1C is not written in stone. You could start off with 7, and as the patient reaches 7, you may go down to less than 7, depending on how your patient is doing. So right now we have a hemoglobin A1C of 7%. I wanted to remind you, and this goes to one of the questions one of the audience, one of the persons watching on the internet was asking about. Why are we talking about sulfonylurea at this point in time? Because right now, the world of diabetology is concerned about chronic kidney disease and atherosclerosis and cardiovascular disease. This is our emphasis now. We want, this is on the left-hand side of the slide, we want patients who have established atherosclerotic cardiovascular disease. We want to try and prevent them from getting worse. We want patients who are at risk for this disorder, having 3 or more risk factors. We want to prevent that from progressing. We want heart failure to prevent it from progressing to death. We want chronic kidney disease to prevent it from progressing to end-stage renal disease. This is our emphasis. Now, this patient does not fulfill the criteria. He's not had an event such as myocardial infarction, or stroke, or transient ischemic attack, or peripheral vascular disease, and he does not have chronic kidney disease at this point in time. He's not in heart failure. And so you may not necessarily want to use an SGLT2 inhibitor or a GLP-1 analog, which is suggested for this category of individuals. Now, I believe that he is on, was he on dapagliflozin? Oh, right. So he's just on metformin, 1 gram once a day. So you can just look at him in terms of hair, which over this side, we are focusing now on glycemic control. He is not controlled. And so you want to consider using a drug that is highly efficacious. But again, he had a 7.9% as his hemoglobin A1C. You just want to drop it by 1%. So highly efficacious drugs are not particularly necessary. The highly efficacious drugs are the the GLP-1 receptor analogs and insulin, of course. And then you have the SGLT2 inhibitors, and of course you have your sulfonylureas. Hypoglycemia is not an issue in this gentleman. He's 50 years old. He doesn't have any renal disorder, and he is overweight. He had a BMI of 27, but you can control his weight with non-pharmacological measures such as diet and exercise. So you could add a sulfonylurea. You could add a DPP-4 inhibitor. You could add an SGLT2 inhibitor. You could add or switch him to basal insulin. You could switch to a sulfonylurea. You could switch to a GLP-1 analog. There are so many drugs that we have now that sometimes you get lost, and that is why we have protocols here to help you. One of the things you need to recognize is that you want to reduce your hemoglobin A1C, and if you add glycoside MR to metformin, you reduce the hemoglobin A1C by 1.8%. And it is quite efficacious, and you can do so in a wide variety of patients. The other thing is, we did say that this patient's risk for chronic kidney disease was moderate because he has a family history of end-stage renal disease. His father died from end-stage renal disease. So you might want to protect him, primary protection. He's normal albuminuric, and you know that if you give him glycoside MR, you will reduce him from going on to microalbuminuria by 9%. So the decision here is to add glycoside MR, and I'm sure that we can discuss whether you think that's appropriate or not, that he is to do physical exercise at least 3 times a week, and of course to reduce his simple sugar intake and his simple carbohydrate to more complex carbohydrate. So we added a sulfonylurea to the patient, and now I'm going to pass this on to you.
Just before we jump to the slide, I would like to mention the Dutch primary prevention guidelines, and they're very simplistic: metformin, glycoside MR, a long-acting insulin. Those are the 3 choices the primary care physician has in the Dutch territories. And the patient is not at control, they are then referred to what we call specialist clinic. And you might say, well, why do we mention glycoside MR specifically? To be fair to the guidelines, I mean, some of them are a little bit politically correct. They mention, 3rd generation SUs. But the bulk of data is actually with glycoside MR. The advanced trial is the biggest trial with an SU in the recent past that has essentially stood the test of time as a very safe, efficacious, and beneficial drug, as opposed to this concept of non-inferior or this concept of cardiovascularly safe. It's an advantageous molecule and should not be, again, thrown out in your armamentarium. So we have a patient in front of us, as we said, who has a vascular risk, if one wants to use that terminology. And therefore, we have to think of now, well, what do I want to add to this patient? And we have these practical choices in front of us. I'll start at the bottom of the pile. Should we add aspirin? Should we consider an antihypertensive? Again, remind his blood pressure is 130/80. Should we start a fibrate and omega-3 because his triglycerides is marginally elevated? Or should we consider a statin? Or maybe all four, but right now the options are these things. But in practicality, these are all parallel thoughts. So this is one of the older slides, but it shows a very nice algorithm of things to think about. So again, cholesterol therapy, blood pressure control, diet, of course, A1C control, antiplatelet therapy, smoking cessation. So the wheel, we call it. So in the wheel, you need to flip what part of the wheel you're on and decide if each parameter is where you want it to be. So if they're smoking, we discuss smoking cessation. If the blood pressure is not at goal, you decide if you want diet and exercise, and then you decide the pharmacotherapy. Prof made a very important point, and I think sometimes it's underplayed. Define your goal in writing. So at your first visit, you can say A1C of 7 is your goal. At your fourth visit, you can say, well, I'm 6.9, but maybe I should aim for 6.5. And you might consider changing your goal. It's a dynamic thing, to be very fair. The flip is true. The patient can come in what we call tightly controlled. And they might say, well, I've now had an MI, and maybe I want to de-intensify therapy, and I might change my goal again. And it's very important, even for your own thought process, even if you're the only person seeing this patient, to document it. It actually comes in quite useful. It sounds like it doesn't, but it actually does. So define it there, and then go back to it over a period of time. So even if you want an A1C as a better goal, if somebody's on already on triple therapy, again, do we want to add a fourth therapy? Again, does that goal justify adding polypharmacy? You know, polypharmacy has disadvantages in its own right as well, not just cost. So in this patient, you know, these are the things that we're going to think about. So just to kind of answer some of the things, aspirin in general is almost never used in primary prevention now. So the patient has to have established cardiovascular disease. You do have the select scenario where patient has a very high cardiovascular risk, so multiple comorbidities if you wish. But even in that patient, you know, giving them antiplatelet therapy does carry some, you know, disadvantage. So in those patients, sometimes what a useful thing to do is to prove subclinical atherosclerosis, a CT calcium score, carotid duplex, very practical tests that one can do. So again, let's say we did this chap, his father had died from chronic disease, but his father's brother had an MI. You might say, well, let me look for subclinical atherosclerosis. And I find a calcium score is elevated. Elevated means, you know, generally above 100. We say, okay, this guy has advanced atherosclerosis, even though his lipids are not that bad. It will change your statin intensity. You might say, I'm going to give him an antiplatelet therapy. But if you just look at the numbers, in of itself, he's primary prevention, and therefore aspirin is not indicated. At this point in time, his blood pressure, again, at least one reading in office, again, that's not the all and end all blood pressure assessment, but at this point, if that's your blood pressure numbers, antihypertensive therapy is not advised. I remember some years ago when a lot of the data came out, you know, we should give everybody enalapril 2.5 mg because they're all diabetic. Again, that's an overkill. Polypharmacy is disadvantageous. It sounds easy in your mind, but when you have to pop pills in the back of your throat, it adds up. The adherence, compliance is automatically going to be bad, because the patient is not going to know what are the top 3 and what are the lesser 3 if you wish. So always think in the back of your mind, do I want to add therapy and how much therapy I want to add? Not smokers, so not relevant. He did admit to that diet about not doing sugary drinks, and of course reinforce that as well and emphasize some other things as well. Physical activity, we've discussed that already. So really the lingering thing is there should be exposure, and I use the word expose deliberately, to statin therapy. Why do I use the word expose? These are not innocuous drugs. A drug is a drug. So do I want to expose somebody to a therapy which actually is potentially dysglycemic? It's been underappreciated, you know, in the early days of the disadvantage of statins, and therefore we should not look at numbers in isolation. You do not expose a 35-year-old patient to atorvastatin 80 milligrams and rosuvastatin 40 milligrams if their only risk factor is elevated cholesterol. that patient, especially if they have metabolic syndrome parameters already, will convert to over diabetes if you watch them long enough. Polytherapy, high-intensity therapy, has a price. And think about it. So you might remember this study some years ago called the Heart Protection Study, and they looked at simvastatin. And one of the take-home messages, if you wish, and I think not wrongfully so at that time, is that almost everybody who's a diabetic, regardless of age, should have a statin. And that was the logic for many years. So you got this knee-jerk, diabetic, add aspirin, diabetic, add a statin, diabetic, add an ACE. And every diabetic ended up on polypharmacy. And this has nothing to do with the A1C control, which also probably has polypharmacy. So now you've subjected this one patient who, if I use the word wrongfully, only has diabetes, now to 5 or 6 chemicals, which is 5 or 6 tablets, 5 or 6 risk. So again, don't downplay this concept. So if we categorize this patient, he is considered moderate risk. So it is reasonable to offer him statin therapy. What is moderate risk? Moderate risk statin therapy means atorvastatin at 10 to 20, rosuvastatin at 10 milligrams or less, and simvastatin at 40 milligrams. So those are moderate risk or low risk doses. I use rosuvastatin 5 and atorva 10 quite frequently, very well tolerated. Just need a little bit of control. Again, don't downplay. Statins have disadvantages. So do I want to expose my 42-year-old patient to statins for the next 40 years of their life? It actually doesn't sound always as wonderful as it sounds. So think about that when you're adding statins. It's not about everybody gets the same thing. It's not about making the LDL the perfect 70 for everybody. If you're exposing a patient to get these targets in polypharmacy, there is potential disadvantage. And that applies to the A1C as well. If the A1C is already 6.8 and you're already on maximal oral therapy, again, do I want to get 6.5 and expose them to insulin? Probably not. Maybe I'm going to be happy with 6.8. Again, that's not set in stone. That could be dynamic as well. If a GLP-1 becomes available, it's cost effective, then yes, I could replace 2 of those drugs with a GLP-1. And I've seen that very well tolerated, basically. So you get, if you wish, this metformin plus background, something, whatever the other something is, and you have a GLP-1. Again, not a very accessible therapy, but again, if it is, one can consider it. So in our environment, simplicity actually is a very important concept. So not to sound third worldish, but you have to think about this practically. The patient in front of you is not going to take many pills. Don't fool yourself. You know, worse yet, if you say this is AM, this is PM, this is pre-meal, this is post-meal, this is nocte, you're confuffling the patient and they will literally tell you, nope, I don't do that, can't take that, basically. So think of this process in the back of your mind. Ask them what they're on, double check whether they're being treated for other things as well, because the list adds up quite easily. And again, you want to think in the back of your mind, choosing therapy that's going to not only give you efficacy, but safety, short-term and long-term. Yes, the benefit is part of your thought process, but is it going to affect my compliance? Because that's going to throw off everything else as well. So in this patient, you can consider statin therapy. What I would probably do is probably consider CT calcium scoring on them. Decide if there's subclinical atherosclerosis. It's better than carotid duplex, but that's also a reasonable option. Again, cost is a reality there as well. So carotid duplex is cheaper than a CT calcium score, but the data is much more validated with CT calcium scoring. And the reason I like it is very visual. So I show the CT, look, you have plaque there, it's there in the LED. So this is not affecting you, it is affecting you. And they see, oh gosh, I have that already. And you believe the motivation dramatically changes, including the willingness to take something for therapy. As you know, we still have a lot of faux pas about, should we take a statin? It has brain effects, it's going to damage my liver, it's going to cause dementia. All the questions come thrown at us. And again, but those are not unfair questions as well. We're asking a patient to take a drug, and we have to be clear that we're taking them to take it for a good reason. So again, think about it, and don't underplay that. And I think Prof made a very interesting comment. Look for things. Looking is part of the disadvantage of medicine now. We have to look for nephropathy, we have to look for proteinuria, we have to look for coronary disease. Don't wait for it to magically pop up. So I don't think the omega-3 is a bad idea, just to say that, because it is a reasonable option for the triglyceride level, but low-dose statin therapy is reasonable. Antihypertensive is not recommended or advised at this time or needed, and aspirin is also not indicated. So this was the follow-up. A1C had improved, which is now in dual therapy, metformin and glucoside, down to 6.7. I assume this is fasting glucose down to 117. Triglycerides has been relatively unchanged. sorry, the triglycerides did improve, 170 to 150. Total cholesterol has improved. HDL has maintained at a good number, and the patient is allegedly exercising 3 times a week and not doing the wrong thing. Questions and answers. Questions. I will try to give you our perspectives and your perspectives as well. Anything from the online? We're overwhelming you guys. Let me ask a very practical reality. Would you have chosen, what you would have chosen for your second choice drug in this person? Because that is a practical thing. You do have choices, you know, and those are fair choices. There's no right or wrong. We're just discussing what we're doing and what is the thought process behind it. Anybody want to take a grab? Don't feel biased because it's a glycoside environment. There are a lot of things you could think about. Right. So in terms of SGLT inhibitor, what is your expected A1C improvement if you add on that?
Something close to 65%.
Nope. So quite, you know, I think, you know, badly thinking. These newer drugs, and this goes back to the days of glitazones as well, DPP4 inhibitors as well. You know, the magnitude of A1C reduction is disappointingly 0.6, 0.7, 0.8% actually. So again, if A1C is your goal, remember that basically. So of course we have all the different concoctions, the different therapies. We will see about this DPP4 being different to this DPP4. As you know, glitazones are used a lot less frequently, although there's very good data on pioglitazone, and at least in Trinidad it's not commercially available. So really, if you're looking at A1C, SUs are very, very useful in front of you. So I would not use the SGLT inhibitor, but think about that in the back of your mind.
Well, let me just ask a question. Why were you contemplating using an SGLT2 inhibitor in this patient? What was your goal?
To reduce the overall cardiovascular risk.
But what was his cardiovascular risk?
Was moderate.
It was moderate. Okay. But does he have established cardiovascular disease?
Not so far.
Okay. It's a valid point. It's a valid point.
The other thing that I would throw out, we have a question there, we'll pass the mic. The other thing I would throw out, and this is actually looking at data, you know, it's easy to look at the end of the slide, but all the DPP4 trials, because that's what you're looking at, are cardiovascular safety trials. Oh, sorry, the SGLT inhibitors, I was talking about that. And the rationale for that was to see, does this add-on therapy, and again, you would add-on is important as well, does it make a difference? If you look at the data, and this sometimes is a little hard to see in the publication, all these patients were on metformin, and close to 70 or 70, I think it's about 80% were on SU. This is not SGLT2 inhibitor therapy compared to nothing. This is SGL2 metformin SU compared to metformin SU. So you're actually comparing triple therapy to double therapy. And although it was not a target-based trial, the A1C still stayed about 8. So if you think about it, adding that drug did not improve my A1C. Again, that was not the purpose of the trial. But in the data, that actually didn't change. So in practicality, again, if that, not that it shouldn't be used, but bear that in the back of your mind. It's one thing to have an SGLT2 on board, but why am I keeping my A1C at 8.5? So again, the take-home message here is don't throw out a class of drugs because you perceived that they're bad. In the list of cardiovascular advantage, there's also the A1C driving point. Is actually a very important point to understand. It's not that we're reserving these drugs for the sickest of the sick, but that's what the data is. The data was used in patients who had actually established disease. These are not primary prevention trials. So look back at the data very carefully. So it's an expensive therapy that potentially may not reduce A1C. And again, not you giving it wrongfully, but what is the advantage of it? The advantage, it may not be practically possible for the next 30 years of this patient's risk.
Yeah, just to be a little ridiculous, what about adding more metformin? Full stop.
I'll let Prof take this.
The patient is on
1 gram.
1 gram BID, and the studies have been done. Greater than 1 gram BID, maximum dose of 2 gram, you will not see a further lowering of the hemoglobin A1C, and you'll see more adverse events of diarrhea, abdominal pain, etc. So it's not worth your while going above 2 grams. But I remember the times when we used to use up to 2.5 grams, but we don't do that anymore.
So generally the options are 850 3 times a day, or 1 gram twice a day, or depending if you're long-acting metformin. This is not a forgotten thing. We all have had patients with metformin intolerance. The worst thing to do is to make them not want to take any drug. So be careful when you try to crank up the metformin in your attempt to have A1C improvement, but they actually stop all the therapy because they get side effects.
Provided that there are no issues with compliance, would you consider adding a basal insulin glargine, for instance, a single dose of insulin glargine?
What is it that you're trying to do? You're trying to get the hemoglobin A1C down. Nothing wrong with that. I mean, I have patients who are on basal insulin, and when they come to the clinic, the residents are like, but can't we stop the insulin? And I say, why would you want to do that? The patient is controlled on the insulin. The patient is not having hypoglycemic events. And after all, the real problem in diabetes is a complete lack of insulin or a relative lack of insulin. So using a basal insulin and controlling the patient is something that can be done. Be mindful, however, that it is maybe inconvenient to the patient. They are at risk for hypoglycemia. They have to eat breakfast, lunch, and dinner the correct times at all times. And so you must choose your patient carefully. You don't want to give your patient a drug that is completely invasive in terms of the quality of their life. Discuss it. It's always to be done with the patient, but it certainly is valid.
There's a trial called the GUIDE trial, GUIDE, and they did try to answer this question, which is a relatively low-risk population. They're on metformin-based therapy, and what can we add? And that trial did not have the SGLT inhibitors because, again, it was not commercially available in mass at that time. And really, the practical reality is, again, what will the patient take? What will the patient be inherent to? And essentially, you can choose almost anything. And once you get adequate A1C, again, the goal, get the A1C down.
We have a question online. At what level of hemoglobin A1C should metformin be started for pre-diabetes? And the answer is, you've diagnosed pre-diabetes, you can put your patient on metformin. We must understand, of course, that we do want the patients to try diet and exercise. It is perfectly legitimate for you to try diet and exercise and review them in 6 months' time. And if you've not seen a change in hemoglobin A1C, or to be fair, I really look at my fastings and my postprandial glucoses, and I divide them into impaired fasting glucose or impaired glucose tolerance. So I monitor them according to what is the problem. And if they have not achieved the goal that I want, it's perfectly permissible for you to use metformin. If a patient looks at me and says, I don't want metformin, that is legitimate. You can say to them, okie dokie, let's try diet and exercise. Refer them to a dietitian, refer them to a gym for them to have exercise. Many persons can do exercise along with a, what do they call them, a trainer. And it works for some patients. So you can give them 6 months to see if you're going to get any changes. But at the same time, you have to screen them for the microvascular and macrovascular complications and treat those accordingly. So again, always is a holistic approach to the patient who's in front of you.
I'll use this word a little bit cautiously, but the good thing about impaired glucose tolerance is that you still have time if you wish. So you're not trying to get this A1C down in 3 months. It's about getting glycemic improvement, over a period of time. Flip is true. If for some other reason they have proteinuria, they may have had mixed glomerulonephritis, for example, as a child. So the diabetes may not have driven them to have the CKD. But the moment IGT comes in, that patient profile has dramatically changed, as well. So again, look up the other things in the back of your mind. So if you have a screening patient, they're in the 40s, the A1C is 6.3, and again, I think we sometimes forget about the actual blood sugars. We see a lot of patients with fasting hyperglycemia, and I'm not sure why, but I see a lot of those patients now. And the A1Cs are not bad, 6.1, 6.2, but the fastings are 140s, 150s. Again, that's a different profile patient. They have glucagon excess at night. It's a different mechanism in the back of your mind. So some in the back of your mind, if you're thinking in the back of your mind, what's the mechanism of this dysglycemia? Is it insulin resistance? Is it pancreatic dysfunction? Is it glucagon excess? They actually have thoughts behind this. It's not just the A1C as a number and get the A1C down. So look at the patient in front of you, have a practical talk with them, see what's their pattern. And you do need numbers. The A1C is not the all and end all. It comes across like it is, but you need to look at the numbers. You'll be quite surprised that the number varies in patients quite significantly. Some patients have terrible postprandials, and that's a different target. Some patients have lows in the day, but they wake up with the 150, 160, as I said, and that's a different type of target that you would want to go. So get the log, do it in your office. A good old random is very useful in your office. Bringing some fastings is very helpful. Every number that you have in front of you, just like blood pressure, gives you more information, and it makes you helps make a decision what you want to do. Do I want to start therapy? Do I want to intensify therapy? All right, so we're 9 on the dot, so I think we're officially going to close. I'll hand over to somebody from the SERVIER team, but on behalf of Prof and myself, thanks for everybody for listening, both online and in person. And of course, we're around if you have any questions post our formal closure.
All right, so on behalf of the team at SERVIER, we just wanted to say a sincere thank you to our keynote speakers today, Dr. Wright Pascoe and also Dr. Dookie, for all of the wonderful information you've shared with us. It's always really great and valuable to get some more insight into, diseases that are plaguing our region and to get cases also that are specific to our region. So thank you so much for that. And we also wanted to say a thank you to all of you for coming out tonight. We know that your time is very valuable and we appreciate you sharing it with us. So yes, thank you very much. We wish you all a safe journey home and enjoy the rest of your evening.
Always, that's one of the important things about these meetings. You learn, you
get
change.
different perspectives of things. And it's good to go back to the ground and hear what are the people doing, what's the logic.
Absolutely. Absolutely.
The cardiologists have jumped into everybody needs minutes and a bit of, I'm like, but why? What is your super paranoia about it, basically, And even some of the endocrinologists, I've seen endocrinologists stopping SUs, but you're running the risk of losing control. What's the reason you want to change?
No. I mean, it depends on whether they're hypoglycemic or not.
I've seen a deliberate, this is in Trinidad, and I was asked, Papa, what's the reason? Why did they tell you they're changing medicine? But they just tell me this is a better drug. Yeah, but your A1C was already
well controlled.
Nothing was wrong with you. And we went to the same level with blood pressure. This was a difficult discussion. You're well controlled on these older drugs, but you're well controlled. And then why are you changing to another drug that is allegedly better and then lose control? Yeah.
I think you must be very, very careful about changing medication.
I don't know what's happening in the surgery, but we've seen it here with the endocrinologist actually. Not so much the primary care physicians, but some of the PCBs, because again, they've been used a lot of